Pulsus Paradoxus. Everybody knows what is meant by Pulsus Paradoxus. And everybody knows that in cardiac tamponade you get Pulsus Paradoxus. But how many of you know the real pathophysiological basis of Pulsus Paradoxus and how to check for Pulsus Paradoxus in actual day-to-day life? The whole purpose of this presentation is to teach you the actual pathophysiological basis of Pulsus Paradoxus and to show you how to measure Pulsus Paradoxus or how to demonstrate Pulsus Paradoxus in a real life situation. So what is meant by Pulsus Paradoxus? Even though it is called a paradox, actually it is not a paradox. It is an exaggeration of a normal physiological phenomenon. In a normal person, blood pressure varies during inspiration and expiration. Blood pressure drops during inspiration and rises during expiration. In a normal person, this difference is less than 10 millimeters mercury. When it is more than 10 millimeters mercury, it is called Pulsus Paradoxus. So what is the actual reason for this difference during inspiration and expiration? What is the reason for this fluctuation of blood pressure? We will analyze it in detail. The function of a normal heart is to pump blood into systemic and pulmonary circulations. To pump blood, the heart has to receive blood. Right atrium receives blood from superior and inferior vena cava and left atrium receives blood from pulmonary veins. Heart is located inside the thoracic cavity. So whatever pressures generated inside the thoracic cavity, it may be positive or negative, directly affects filling of the heart. During inspiration, diaphragm moves down and thoracic cage moves out. That creates or generates negative pressure within the thoracic cavity. The opposite happens during expiration. Diaphragm moves in or up and thoracic cage moves inward, generating positive pressure within the thoracic cavity. Now we will see how this negative and positive pressure is going to affect filling of the heart. We all know that distal part of superior and inferior vena cava are outside the thoracic cavity. So whenever there is negative pressure generated within the thoracic cavity, it will suck blood into the thoracic cavity through superior and inferior vena cava. That means there will be more blood coming into the right atrium, which means more systemic venous return. And this more systemic venous return goes into right ventricle, so there will be more right ventricular stroke volume during inspiration. So what happens to pulmonary venous return during inspiration? Pulmonary veins are all located within the thoracic cavity. Even the distal most pulmonary veins are located within the thoracic cavity. So during inspiration, when there is negative pressure within the thoracic cavity, blood will pool within the pulmonary veins and within the lungs. Because of this pooling of blood within the lungs and within the pulmonary veins, there will be less pulmonary venous return to the left atrium. So that smaller volume of blood will flow into left ventricle, so left ventricular stroke volume will be less during inspiration. So in summary, during inspiration there will be more RV stroke volume and less LV stroke volume. It is purely because of negative pressure generated within the thoracic cavity during inspiration. The opposite happens during expiration. During expiration, the diaphragm moves up and thoracic cage moves in, generating positive pressure within the thoracic cavity. So when there is positive pressure within the thoracic cavity, it presses on the superior and inferior vena cava, the part within the thoracic cavity, preventing blood flowing from the extrathoracic IVC and SVC into the intrathoracic SVC and IVC. So the right-sided flow drops, or the filling into right atrium drops during expiration. So during expiration, the right ventricular volume drops, so right ventricular stroke volume drops. So what happens to the left ventricular stroke volume? The pulmonary veins being totally within the thoracic cavity, they get squeezed when the intrathoracic pressure goes up during expiration. So when pulmonary veins get squeezed along with the lungs, there will be more pulmonary venous return into the left atrium. So there is more pulmonary venous return into the left atrium, so more blood will flow into left ventricle. So left ventricular stroke volume rises during expiration, where right ventricular stroke volume drops. So the reason for the drop in blood pressure during inspiration and rise in blood pressure during expiration can be explained through this physiological phenomenon. So to explain this phenomenon better, we will take an echocardiographic picture. This echocardiographic image shows all four chambers of the heart: the left atrium, left ventricle, right atrium and right ventricle. They contract and relax during cardiac cycle. So during inspiration and expiration, when blood flows into these chambers, they have enough space outside, or they can expand outwards to accommodate that additional volume of blood which flows into atria or the right side during inspiration and left side during expiration. But the situation is different when you have a pericardial effusion around the heart. Cardiac chambers cannot expand outwards because pericardial effusion restricts the heart or the cardiac chambers from expanding outwards. So when it cannot expand outwards, what will happen when more volume of blood flows into right ventricle and right atrium during inspiration? Whenever there is more volume in the right ventricle, when it cannot expand outwards, invariably the septum will get pushed towards the left ventricle. That is what you clearly see in this echocardiographic image with a pericardial effusion. The opposite happens during expiration. When the blood in the lungs and pulmonary veins gets squeezed due to positive intrathoracic pressure, there is more volume of blood into the left side of the heart. So the left ventricular volume becomes more, and that pushes the interventricular septum towards the right ventricle. So when you compare these two echo images, the normal heart and the pericardial effusion, you can clearly see in the normal heart, the interventricular septum does not move at all during inspiration and expiration, but in the patient with pericardial effusion, the septum bounces towards the left side or towards the right side depending on inspiration or expiration. So in a patient with pericardial effusion, during inspiration, the additional volume of blood that comes through SVC and IVC into the right atrium and right ventricle will push the interventricular septum towards the left ventricle, because during inspiration the right ventricular volume becomes more and left ventricular volume becomes less. This leads to a significant drop in blood pressure during inspiration. So the exact opposite happens during expiration. There will be less flow into the right side of the heart and more flow into the left side of the heart, because during expiration, due to positive intrathoracic pressure, the lungs and the pulmonary veins get squeezed and there will be more flow into the left side. So when you have more volume in the left side, the left ventricular stroke volume becomes more, so there is a rise in blood pressure, and in addition, because of this high volume in the left ventricle, the interventricular septum gets pushed towards the right ventricle, affecting filling of the right ventricle. So this echocardiographic image clearly shows how the interventricular septum moves towards the left ventricle during inspiration and towards the right ventricle during expiration in a patient with pericardial effusion or constrictive pericarditis. This is mainly because of more inflow to the right side of the heart during inspiration due to negative intrathoracic pressure, and more inflow to the left side of the heart during expiration due to positive intrathoracic pressure. When the cardiac chambers cannot expand outwards, what will invariably happen is the ventricular septum will move either towards the left side or the right side, affecting filling of the opposite ventricle. This ultimately leads to a significant rise in blood pressure during expiration and a significant drop in blood pressure during inspiration in a patient with pericardial effusion or constrictive pericarditis, which actually is an exaggeration of a normal phenomenon. So this explains the pathophysiological basis of Pulsus Paradoxus. In next few minutes, we will learn how to demonstrate Pulsus Paradoxus in a real-life situation. To demonstrate this, you will only need a blood pressure apparatus and a stethoscope. So how do we do it? First, you apply the blood pressure cuff around the arm of the patient in a usual manner and inflate the cuff to a level above his systolic blood pressure. That is what we usually do when we want to check blood pressure in a normal patient. Then gradually lower it as we do it in a normal patient to check his blood pressure. So when you start lowering the blood pressure, you will start to hear Korotkov sounds. You should mark this appearance of Korotkov sounds, the blood pressure, at which you first heard the Korotkov sounds. If you keep the cuff pressure at this point, you will notice that you hear Korotkov sounds only intermittently or irregularly. So what is the reason for this irregularity? In a patient with pulsus paradoxus or cardiac tamponade or pericardial effusion, you know that there is significant variation in blood pressure. There is rise in blood pressure during expiration and drop in blood pressure during inspiration. So at this point, what you hear are actually the higher peaks of blood pressure which you get during expiration. So you need to mark this pressure as the blood pressure during expiration. Then you should start to reduce the cuff pressure gradually. When you do this, you will start hearing Korotkov sounds more and more. You will hear more and more Korotkov sounds. But still, the Korotkov sounds you hear are at an irregular interval. They are not regular. So you need to keep lowering the cuff pressure further. When you lower the cuff pressure further, at one point you will start to hear Korotkov sounds very regularly. This happens because you start to capture all the Korotkov sounds generated during inspiration as well as during expiration. So you need to mark this pressure as pressure generated during inspiration. This is the point where you start to hear the Korotkov sounds generated by low volume pressure curves generated during inspiration. So now you have pressure generated during inspiration as well as pressure generated during expiration. When the difference between these two is more than 10 millimeters mercury, we call it Pulsus Paradoxus. So during this short presentation, we have learned the pathophysiology of Pulsus Paradoxus and how to demonstrate Pulsus Paradoxus.